The other day I was conducting a table viva for clinical examination of the cardiovascular system, and the question was on auscultation of heart sounds, and these are the answers that I got during this viva. Some of the answers. How do you identify first and the second heart sound? And the answer given was lubb dub. Nope, nah, that's not correct. You can't differentiate lubb and dub. Why are the areas named as mitral area, tricuspid area, aortic area, pulmonary area? And the answer given was because the valves are located there. Nah, no, again. So I could sense that the students read theory, they perform the clinical skills, but they are unable to integrate the two. And that's the purpose of this video on heart sounds. We will integrate the theory with the practicals so that if it's a short note, you will be able to write the answer, and if it's asked in the clinical examination, still the answers will be right there. So let's start. But before we proceed, we have started new sections on our channel like clinical case based MCQs and graph related discussion. So before we proceed, why not subscribe to the channel? Okay. So heart sounds, we will try to answer all the 5 W-ish questions related to the heart sounds. How the heart sounds are produced, when are they produced during a cardiac cycle, where they can be heard best, why do we have to differentiate between first and the second heart sound particularly, and what is the clinical significance. Alright, so in each heartbeat, we hear the sounds which are called as heart sounds, and there are 4 heart sounds produced in each cardiac cycle. Point number 1. Mechanism of sound production. Now each heart sound is produced by 3 components: the valvular component, the muscular component, and the vascular or blood component. This will be required in the theory. The valvular component, particularly important for first and the second heart sound. As the valve is closing, there is vibration of the valve leaflets, and those vibrations produce the sound. Then muscular component. As the valve leaflets are moving, the muscle in the vicinity will vibrate, and that will add to the sound. And vascular or blood component. As the valve is closing, the blood in the vicinity will show turbulence, and that will add to the sound. So 3 components make every sound, particularly first and the second heart sound, which are produced by the closure of the valves. Alright, so that's how the sounds are produced. We answered the first question, how each sound is produced, as 3 components put together will produce a particular heart sound. Alright, now clinically, the heart sounds may be heard by stethoscope over the precordium. So we are answering where the sounds could be heard, or where are they heard best. Well, I found that the students confuse between pericardium and precordium. Pericardium, the coverings of the heart. Precordium is area of the anterior chest wall overlying the heart. Area of the chest wall in front of the heart is called as precordium. And on this precordium, we have defined 4 areas where we will auscultate for the heart sounds. So the 4 areas named after the valves: mitral area over the apex beat, tricuspid area generally taken at the lower end of the sternum, and then pulmonary and aortic areas. Valves are not situated over there. So why are these areas named after the valves? Look, for instance, let's say mitral area. Mitral area is located over the apex beat. So here is a diagrammatic view. Left atrium, left ventricle, and between the two is the mitral valve. So the sound produced by the mitral valve is transmitted and heard best over this area, and therefore it is named as the mitral area. Similarly, tricuspid area. So here is a right atrium, then right ventricle, and between the two is the tricuspid valve. Sound produced by the tricuspid valve will be transmitted and best heard at the lower end of the sternum. And same goes for aortic and pulmonary areas. So the answer is, the areas are named after the valve because a sound produced by a particular valve is heard best in that particular area. Let me just add here about the mitral area. Even if you have a question on auscultation of the mitral area, your examination should start with inspection. Yes, inspect the precordium because mitral area is located over the apex beat or apex of the heart. So first watch, where can you see that pulsation? Then palpate, finally locate the apex beat and then proceed with your auscultation of mitral area. And let's see where these areas are located. Mitral area, we said just now, over the apex beat. Tricuspid area, lower end of the sternum. Some clinicians would say it is in the fourth intercostal space and slightly toward the left of the sternal border. That's okay, but generally accepted as the lower end of the sternum. Aortic area, second space, right sternal border. Pulmonary area, second space, left sternal border. So aortic and pulmonary areas are located in the second intercostal space, right and left sternal borders respectively. These are the areas where you will auscultate for the heart sounds. So we have said this already, sounds produced by the respective valves are heard best in those corresponding areas. Let's talk about the sounds, individual sounds. First heart sound. We would know three things about the first heart sound. It occurs at the onset of ventricular systole. So we are answering when are they produced. First heart sound, onset of ventricular systole. It is caused by the closure of the AV valves and therefore heard best in the mitral and tricuspid areas. Since it is produced by the closure of AV valves, it is heard best over the mitral and tricuspid areas. These 3 points are or should be known. Once you read the cardiac cycle, these 3 things become obvious to you. Okay. Then clinically, while auscultating the heart, S1 is recognized as the sound that corresponds with the carotid pulse. So how do you differentiate between a first and the second heart sound? Look, first of all 4 sounds cannot be heard normally. 4 sounds are produced during a heartbeat, but only 2 can be heard clinically. How do you recognize S1? Okay, S1 corresponds with the carotid pulse. So a very important point or a common error committed by the students, they would say, I could differentiate by hearing lubb and dub. No. Once you have put the stethoscope, within next 5 seconds, what you are also supposed to do is put your fingers over the carotid pulse. This is a must-know area. Okay, you will lose marks if you don't put your fingers over the carotid pulse. So you palpate the carotid even as you auscultate the heart sounds. Why? Why is it that the first heart sound corresponds with the carotid pulse? It is because here the ventricular systole starts. At the start of ventricular systole, there is closure of AV valves. So S1 produced, and at the same time systole generates that pressure wave which comes as a pulse. Pulse comes with every systole. So first heart sound produced, and at the same time the pressure wave generated and is felt as the carotid pulse. So the sound that comes with the pulse is the first heart sound, and the sound that comes between the 2 pulsations is the second heart sound. Pulse comes intermittently. So between the two pulsations, there is a gap. And the sound that comes in that gap is the second heart sound. Why? Because second heart sound is produced at the onset of ventricular diastole. With ventricular diastole, there's no pulse. There's a gap. So, three things about the S2. It occurs at the beginning of ventricular diastole. Point number 2, it is produced by the closure of aortic and pulmonary valves, semilunar valves. And point number 3, therefore it is heard best over the aortic and pulmonary areas. So about S1 and S2, we know these 3 points definitely. It comes between the two pulsations, that's S2. Alright, note this one point, and I have specifically included in this point in the video because students err. They make a error over here. Both S1 and S2 are heard over all 4 areas. Yes, I repeat once again. Only 2 sounds are heard, S1 and S2, and they are heard over all the 4 areas. But S1 better than S2 in the mitral and tricuspid areas, and S2 better than S1 in the aortic and pulmonary areas. And the reason, now you know the reason, it's very obvious, because S1 is produced by the closure of mitral and tricuspid valves, so it's heard best in the mitral and tricuspid areas. And same with S2. S2 better than S1 in the aortic and pulmonary areas because it's produced by the closure of those 2 valves. Very often the students would say S1 is heard in the mitral and tricuspid areas, S2 is heard in the aortic and pulmonary areas. I have come across this error very often, and therefore I have included this point. Both sounds are heard in all 4 areas. Okay, and how do you recognize S1 and S2? We have done that already. No lubb dub, but with the carotid pulse. Okay, now third heart sound. It is produced during the first rapid filling. So as the diastole starts, ventricular diastole, there is first rapid filling, diastasis, and last rapid filling. First rapid filling produces S3. Because it's a rapid filling, the blood goes with a certain turbulence from atria to ventricles, and that produces S3. And it is due to the turbulence of blood. Okay, fourth heart sound. Last rapid filling produces S4. Now this last rapid filling is because late in the diastole, atria contract, atria go in systole. So this contraction of the atria causes one more time the turbulence of blood from atria to ventricles, and this will produce S4. And therefore remember, S4 is also sometimes called as atrial sound. It's caused by the atrial systole and therefore the turbulence of blood. So S4 due to the gush of blood from atria to ventricles, and it's occurring because of atrial systole. So this is how the sounds are produced. We have answered how the sounds are produced, when they are produced, we have already answered that, where you can hear the sounds and which sounds can be heard better. So all these answers are given satisfactorily. Okay, third and fourth heart sounds are not heard normally by stethoscope. Sometimes in children you can hear the S4, that's possible, but otherwise normally only 2 sounds. So just make a differentiating feature. If it's only 2 heart sounds, then it would be like duk duk, duk duk, duk duk, or lubb dub, whatever you want to call it. But then if it's a third heart sound also along with S1 and S2, if S4 is also heard, it will be 3 sounds. Then it will be like a gallop. Tagadak, tagadak, tagadak. This is 3 sounds. Okay. So you practice and you will get to differentiate between various sounds, 2 sounds, 3 sounds, etc. Now these sounds, well, although you cannot hear S3 and S4, but those sounds, and in fact all 4 sounds are recorded, they can be recorded by phonocardiogram. So another Viva question answered. How can you record the sounds? The answer is phonocardiogram. And what will happen here is that it will give you a graphic representation or diagrammatic representation of the heart sounds. So systole started and then S1, then diastole started S2, and then there would be S3 and S4 in the later parts of the diastole. So phonocardiogram, it requires a transducer and an amplifier. Transducer will cause conversion of sound energy into the light energy, and then amplifier, and it will give you a graphic recording like this. All right. So all these things, how, when, where. Now we will come to the clinical significance of this. First point is, why do you have to recognize S1 and S2? This is a question which can be asked in the clinicals. Why do you have to know that this is S1 and this is S2? It's because there are adventitious sounds called as murmurs. Murmurs can be systolic murmur or diastolic murmur. And to differentiate, we have to know which one is systole and which one is diastole. That is why we have to know the S1 and S2. The murmur that will immediately follow the S1 will be the systolic murmur. And the murmur that will immediately follow the S2 will be the diastolic murmur. So we have to know which time period is systole and which one is diastole. For that, we have to know the S1 and S2. All right. So murmurs, that is the applied aspect of the heart sounds. If you have a short note, these are the adventitious sounds or foreign sounds heard during the auscultation of the heart. Murmurs are generally produced due to the valvular heart diseases. What are the valvular heart diseases? Stenosis and regurgitation. Two types of valvular heart diseases, stenosis and regurgitation. You will read about it later on in medicine, and I'll make another video on that. But just for example, stenosis. What is stenosis of a valve? When the valve leaflets adhere to each other, they cannot move freely, and the valve orifice is narrowed. That's the condition of stenosis of a valve. The valve leaflets adhered to each other and the valve orifice is narrowed. And since the blood has to go through that narrowed orifice, the blood goes with turbulence, and that turbulence produces the murmurs. So murmurs are produced because of such valvular heart diseases. That's the clinical application. And finally, as we have added the Physio plus plus feature in all our videos, what could be the Physio plus plus? And if you add this in your answers, you are going to get extra marks. So for this video, I'm taking splitting of S2. You know, two heart sounds are heard by stethoscope, S1 and S2. Sometimes, and this is physiologically, there can be a splitting of the second heart sound. When does this happen? This happens with forceful inspiration. Forceful inspiration may cause physiologic splitting of the second heart sound. And how do you remember this? Remember it like this: S2 is equal to A2 P2. S2 is equal to A2 P2. Aortic, pulmonary. You know, second heart sound produced by the closure of aortic and pulmonary valves. What happens during forceful inspiration? The lungs are distending and they create a great negative intrathoracic pressure. Because of this negative intrathoracic pressure, more and more blood is sucked towards the right side of the heart. Venous return to the right side of the heart will increase. Which means what? Which means right ventricular filling gets delayed. Therefore, right ventricular systole also gets slightly delayed, and therefore, at the end of it, the closure of the pulmonary valve will also get slightly delayed. You know, right ventricle is pumping the blood through the pulmonary valve, and therefore closure of pulmonary valve gets delayed because of the increased right ventricular filling with forceful inspiration, and that will cause splitting of the second heart sound. Normally, both the valves close simultaneously and one sound is produced, that is S2, but in such situations, it may get split and it's called as A2, P2. Aortic valve closed first and pulmonary valve closure was delayed. All right. This can happen in pathological situations. For example, paradoxical splitting of S2. Paradoxical means P2 will close first, P2 sound will occur first and A2 sound will occur later. So splitting, but reverse splitting, paradoxical splitting, or rather we should call it reverse splitting. So it would be P2, A2. Now the question is, why the aortic valve closure got delayed? It occurs in severe aortic stenosis or the conditions like obstructive cardiomyopathy. Now consider aortic stenosis, severe aortic stenosis. What happens is left ventricle will be hypertrophied. It will generate great pressure to pump the blood through the stenos, the aortic valve, and therefore left ventricular systole will get prolonged, and therefore aortic valve closure at the end of it, that will also get delayed, and in that case it will be P2 followed by A2. That will be reverse splitting of the S2. However, this was the integration of the theory and clinical understanding of the heart sounds.